Well, we've got that expectant hush, so I think we better start. Warm welcome, colleagues, to this Trust Board held in public. It's a really long agenda, and I'm really pleased with that, because this is a sign that we are progressively moving more material into public board, and as a consequence, much less into private board. So just to take stock for colleagues today, we've got well over 2 hours worth of work this morning. We then have a charity corporate meeting. I always forget the terminology of that. Corporate trustee, thank you. And then we have private board, which as a consequence of fitting most of the work into this morning, private board will be shorter this afternoon. You will be relieved to hear. Looking at the length of this agenda, and there's plenty in it, if we will manage it, then I'm intending to introduce a 5-minute break halfway through, but let's see how we get on. Can I remind colleagues that because it's public board, first of all, we have, I think it's only Alexios here in person, but we don't, and you're very welcome, Alexios. I'm not quite sure how many people will be following on streaming, but to remind you that in recent months, we have several hundred people that observe the board on recording on YouTube. So just bear that in mind in your comments. But at the same time, that is not an encouragement to stifle challenge and criticism. As we all know, that's what we want from this board. So, thanks for that. Apologies, Ruth is running 15 minutes late, so she's on her way. Apart from that, Jeremy said apologies. And Phil is intending to join us online. I haven't seen him yet, but he's in it's Qatar or Dubai, one of them, doing a bit of business, including some potentially for us. So, and he was saying he's having a little connection problem. Apparently they haven't invented the internet in the Middle East yet. But so we'll either see him or we won't see him, as things go. Nothing else? Can I check first of all, are there going to be any other businesses you want to alert me to for this public meeting? No, in which case shall we go straight into the agenda, which is the minutes of the meeting dated 27th of March. There are some, I think it's fair to say, trivial tweaks to one item in the HR section that Kate is providing me with some wording for. So I'm going to ask you if you will approve the minutes subject to any minor amendments that Kate might bring to us. Is that acceptable? Thank you. Are there any matters arising from those minutes? No, it's all very, very clear, I think, and very, very straightforward. Thank you. And the action log is one of those beautiful action logs which is either all green or not yet due. So I've got no issues arising. We're on top of all the actions arising out of public board, unless anybody has got any other issues to raise. Then we're into my introduction. I think I've done it, so let's go straight on to the Chief Executive's dashboard.
Yep, so you will have seen, thank you Paul, you will have seen the dashboard that we usually share at board meetings. This is the one for April. A positive start to the year so far. So in terms of all of the core things that we would normally talk about, finance, workforce, performance, a real positive start. We've delivered, and you'll hear from Paul later on today, in terms of our financial plan for month 1. And underperformance, some of those still remain red, but are actually, when we nationally benchmark, we're in a really strong position. So the ED performance, for example, at 89%, just shy of 90, which is what we had planned for this month. So let's see where May ends up landing. And I think what was really positive to see was that, for all we haven't met the 85% 62-day cancer standard, that's tipping in the right direction again now after we had that blip earlier start of the calendar year. It's not reported on here, but in terms of our long waiters, in particular those waiting over 52 weeks, again, I think it would be good for board to be aware that we've hit 15 patients now.
How many?
15, which is the lowest that we've had for quite some time, and a phenomenal effort, I think, particularly by the surgical business unit, to get that number down And I already know in May it was down to 14 because we saw one of those patients very early on at the beginning of May. So hopefully that will continue on the downward trajectory. The other thing just to note is that we have now put into our planning documents the 3 key focus areas for the organisation. This was on the back of trying to simplify some of our big signals. When we have been undertaking the staff roadshows, what our staff were telling us was that the 3 words that really resonated with them was that the organisation was about our patients, our staff and improvement. And I think that message is landing well through the roadshows that are going on at the moment. You'll start to see that more and more across the organisations. We focus on those 3 things. A big capital plan for the year ahead. This is the year that Berwick delivers. We've been talking about that for quite some time, so we look forward to that. And then we've obviously got other capital investments in particular with regards to Seton Delaval and Hexham. So they are now well underway and are currently due to deliver on time. And then lastly, our patient experience and our staff experience. April we had our real-time staff programme. I think Joe's going to talk about that later on, so I won't go too much into that. One to note is under patient experience, strong in terms of our real-time ward visits and emergency care. You will remember we've been running that now for just under a year. We have managed to tip out on top of, in terms of the average score, was 9.25, which was well above the baseline of 8.8 when we first started the programme. So again, heading in the right direction. It's not in the same league as what our ward reporting is yet, but it's on a strong upward trajectory.
That's great, Luigi. Maybe only fair to note that although we've managed to get the long waits down to 14, we had a target of getting it down to 0, and we still very much aspire to do that as soon as we can. Any questions or comments or challenges or clarifications to Bijou? This is a dashboard that's gone through a few iterations, so people have had a chance to comment previously. Thank you very much indeed. And it's still you, I think, but as we go on to the Chair and Chief Exec update, maybe if I just say one word first of all, because this paper includes reference to the issues that are brought up by governors, and I just wanted to know, I thought the governing body meeting last night was particularly good. There was some real challenge, but some real debate, real recognition of where we're doing well, but it felt like it had that kind of tone that I think we've been aspiring to, that some proper debate and some proper things that we go away thinking, yeah, we've got a bit more work to do. So I appreciate everybody's input to making that. It feels like we're in quite a good place with the governors at the moment. But Bijou, if you want to introduce this.
Yeah, so this is the Chair and Chief Exec engagement update. I'm not going to go into detail through the whole paper because I know you'll have had the opportunity to have gone through this, but just a couple of areas I think in particular that are worth mentioning. The bilateral board that we have with Newcastle under the banner of the Great North Healthcare Alliance continues to work well. We've got some strong examples now of where we've seen real improvement for patients. So I quote, we're routinely respiratory and cardiology in particular. And we want to continue that forward. Audiology is also, we've seen through the governor's meeting, Newcastle presenting about the improvements we're starting to see in audiology. There's still more work to do, and recognition there's more work to do in that area, but it is heading in the right direction. We've had and held a number of learning and improvement events. The most recent one was earlier this month around elective care and urgent emergency care. That's run across the whole footprint. Myself and Lynn Simpson chaired that one. We had people both from the regional team, who's the Chief Exec of North Cumbria Trust. Well attended, well evaluated, and there are more of those sessions now going on, particularly under the banner of the National Learning and Improvement Networks. Also worth, I think, just to mention of last time, I think we spoke about the Trust visiting Maidstone and Kent for some learning. We had they come to us, we've had a reciprocal visit to them. which has been really, really well received. And I think the team got a lot out of the visit, and lots of learning to pick up, and that there are some of those practices that we have started to implement here, particularly around their cancer pathways and cancer monitoring and some of their 18-week and 52-week monitoring. And I've also had the opportunity to meet now with the new regional director, Fiona Edwards, which was really positive. I think we were both on the call as well. And I think that relationship and that help, particularly as things change across the NHS landscape, will prove to be really important.
Very good. And if I can just add to my section, sometimes it's hard to be able to point to measurable outcomes from partnership working, because by their nature, if there's a positive outcome, the credit is properly shared. But I've got a better example than normal here. In the last week, we received confirmation here in Northumbria of £20 million of public sector decarbonisation funding support, and in Newcastle, £40 million for similar work decarbonising, which together is the largest grant anywhere in the NHS this year. And my understanding, reasonably well-informed understanding, is that part of the reason why we did so well is because the North East Combined Authority lent its weight behind the recommendation. In other words, it was seen not just as the NHS doing its own thing, but part of a partnership approach to net zero. So I can't slightly counting that as a win for our partnership work, at least a shared win for our partnership work. Really happy to take any questions or comments on the work to catching of what Bijou and I are doing in partnership work.
I'll just add one other thing. We had the annual quality review, the ADQM visit from the regional visit and annual deanery quality meeting, and we received as an organisation a very, very positive report on the back of that, and I think the teams should be congratulated for the effort not only to for that visit and the input that's needed in that visit, but actually it's all the training and education that goes on for all of our staff, and on the back of that, we should know that.
Steve.
Thank you, Chair. Just a point from your item there about the decarbonisation funding. I just wonder whether there's opportunities that we're exploring across the Alliance to schedule works and to procure collectively, because my understanding is that there's savings to be made from managing the market and allowing contractors to schedule things in a sensible series of events that could save overall the two trusts some money.
Paul, are you in a position to say something? Probably I am as well, actually, but you can help.
I mean, I'm aware that the estate directors talk on a regular basis, and I'm sure there will be, but I'll follow up with him just to...
I've met with the sustainability leads from both trusts since the announcement, and they are working closely together, and they're feeling confident about the ability of our procurement teams to work collectively. So I think we've got a good news story on that. But it's not easy. It's expertise is short. Any other points following up from that report? Thank you. Well, an awful lot of self-congratulations so far, so let's go into challenge mode. Just as Johnny comes on the scene, the Child Health Business Unit, the opportunity for us to reflect and be updated on how things are going. Johnny, you've got a lot on.
Yeah. Well, thanks very much. So those that don't know, I'm a community paediatrician. I work up in Northumberland in Berwick and at Wanspec and the business unit director for Child Health.
Speak up a bit, will you?
I can move a bit. Is that a bit close? Is that better?
Thank you.
Yeah. So the first slide really just describes the different services that we have in child health. I think everybody will know about acute paediatrics and second special care there, but we have a lot of services across community settings as well as mental health services. We have the CAMS team in North Tyneside and primary mental health workers in Northumberland. We have about 30 primary mental health workers now, and specialist nursing teams, including children's community nursing, and our immunisation team that work in Newcastle and in Gateshead as well as Northumberland and North Tyneside. So it's a big team across well, it's actually a small team comparative to the Trust, but it works in lots of different settings. We have 338 staff and a budget of just over 23 million. The next couple of slides are about our patient feedback, and we've done quite a bit of work over the last year to improve collection of patient feedback across different services that we provide. I won't go into detail actually about it because it's a relatively short presentation, but we do really well, I think, in terms of feedback across the different services that we provide to patients and to families. One of the things that we want to do over the coming year is, as well as getting patient feedback and patient experience information, actually developing more of a programme to involve young people and families in the development of services and new service design. And we've had some positive conversations with Joe about that, and hopefully we'll make a bit of progress this year. I did hear this morning that the CQC survey for the acute paediatric unit at NSEC was a positive outlier in terms of patient experience, which is, I think it's just been published this morning. I've not looked at the detail of that, but that's really great news, I think, for the team there. In terms of our patient experience as well, there are some health inequality data information that we ask on our outpatient surveys, and actually for the patients that attend clinic, we've not found a strong theme to that yet, although it's a relatively small number of children and families that we've had information back on. But there's some further work this year trying to understand the children that aren't brought for appointments and what might be the reasons behind why they're not coming along to clinic. But they are a difficult group to actually reach sometimes in terms of direct conversations with them. Our staff's experience, I think we do really well in terms of staff experience in child health. Comparative to other clinical business units, we always score well within the organisation and nationally too. There are some teams within the business unit that have had perhaps less positive scores, and so we do some direct work with teams when that's identified through staff experience or from other information that we receive. And we've just completed a bit of work in one of the teams at NSEC, and we're waiting to see how that goes with embedding some of the recommendations and some of the work around the culture in that team. In terms of recruitment and retention and staff a bit further, we are really successful in recruiting medical staff into the child health acute team, community team, and the CAMS team, which is a real positive. Some of those services in other places struggle. I think that's partly because it's a good team to work in, but it's also a good organisation to work for as well. I think people see that. We've appointed clinical educators in acute and community paediatrics, which is a real positive for those nursing teams in particular. We're very reliant on advanced nurse practitioners in our special care service, in our acute paediatric service at NSEC. They're a really valuable, essential part of the team, and there's a continued programme of training, recruitment, and sort of planning really for what we might need in the team as a whole, succession planning as well. There's been some expansion in nursing on special care to make sure we're compliant with the PAPM standards for that, but also recognising the increased deliveries at NSEC and the increased work of the team. In terms of performance, it's busy clinically, so our A&E activity continues to increase year on year. Our outpatient activity continues to increase year on year. We do provide advice and guidance for primary care, and that as well continues to increase. I think from a performance perspective, our 4-hour wait up at NSEC is very much usually over 95%, apart from perhaps a few weeks in November and early December, which are our busiest times. but on the whole, the 18-week target is met, and the 4-hour target too. And similar in terms of activity, our CAM service is busy, increased referrals and some increased complexity in children and patients that they see through that service. We've had quality panels in a couple of our services and had a good outcome from those, and similarly 15 steps over the last year, again with good outcome for those too. In terms of the inequality and climate change and other things that are going on wider within the organisation, I think child health is part of that. Actually, the sustainability issue is one of the things that children find is most important to them when you ask them questions about what they worry about and think about going forward. There's been some poverty proofing work done in CAMS, and also the design of a children's menu on the acute unit 2 involving children and dietetics for that. And as I say, I think we do need to do more work about actually speaking to patients and to families about why they're not able to come to clinic, but also why we have such a large number of young people that come up to NSEC for acute care as well, and understand that a bit more rather than just seeing the figures. And we've got some help offered from the public health team in the trust to answer or to look into some of that a bit more. Over the next year, we were successful in receiving some funding from the ICB to develop a neighbourhood multidisciplinary team for children and young people, with a couple of pilots starting in Northumberland. So CC4C is an example of a multidisciplinary children and young people's team. That's the London model from Imperial, and it's been shown to reduce unnecessary referrals to outpatients, but also reduce attendance at A&E for children with minor intercurrent illness. We've got some buy-in from primary care in the Wansbeck PCN and Blythe PCN. Our primary mental health worker team are involved in social services through the Family Hub. So we're really hopeful we'll get a couple of them up and running in the next month or two, one in the Wansbeck PCN and one in Blythe. Yes, so about the primary mental health worker team, we've had further in recruitment to that service, so we've now got over 30 primary mental health workers in Northumberland, and there's been some managerial changes to support them there. We have paediatric epilepsy nursing too within the team, and they've started to take on, they already do some prescribing, we're going to take on seeing some new patients in clinic and develop that role. So there's lots going on digitally in the trust, and child health is also got lots of different projects underway. Badgenet is the electronic patient record that we're going to use in Skaboo. It's taken some time to get that properly to the position it's at now. We're hopefully going to get that, I think, implemented around November time, perhaps a little bit earlier. We started to do digital prescribing in CAMS through System 1, and we're going to be doing that too in children's outpatients through a different digital system. There's also some videos which have been done with communications around the different immunisation initiatives which are ongoing for children and for families to look at, but also some videos about common presenting conditions to NSEC to give advice about how they can be managed without having to come to hospital settings as well. This is the nicest slide, so it's shame to miss it. So we've been really pleased over the development of the estate over the last year. So the top picture of the trees on, and the next one alongside that is Blythe Outpatients at Blythe Community Hospital. And so we've got a new children's outpatient suite there with 5 consulting rooms, some really nice space for children to wait for appointments, a group room for multidisciplinary assessments, a teenager room which is waiting, a very big TV to be put up. And it's a really nice site, really pleased with that. We can increase the number of services we provide in Blythe. The bottom two up at Wansbeck Outpatients and the Bright Charity, they helped in funding some of the resources for blind, but also supported a play area for children outside of Wansbeck, and there's a bit more work to do in the Wansbeck area, but it's a really nice development. And we're hoping later on this year there'll be some developments around Riverside and Meadowell down in North Tyneside as well, which should be great. I think I've mentioned most of the things on this in the other slides, so I probably won't talk a great deal about it, but it's just the importance of working with the different agencies that are important in children's lives, so social care and education. We do a lot of that in child health, but also with other health organisations, Newcastle and other partners in the Northern Alliance. I think relationships are very good at the minute and thinking about how we develop services going forward. We do have some additional resource in North Tyneside CAMS through an organisation called Helios, which is helping to undertake some of the new developmental assessments that children are waiting for. So we still have a lot of children waiting for assessment, but the waiting time is much reduced, which is really good. So taking stock, a busy year. It's always a busy year, I think, when I give this update. But I think the team are really, they're really engaged, a really good team. We've got excellent patient satisfaction survey, excellent staff results as well. They're an innovative team, I think. They like to think about, with all the pressures that we've got around finances and resources, look at how we can improve patient experience and patient flow across the different services. The pressures, particularly around children and young people's mental health, that remains a big pressure. Our special school nursing service, more children have got special educational needs, more children are attending special school, and some of those children need medical nursing input, in particular, or therapy input. And that's causing quite a strain on the service. And I'm confident that the fundamentals of the business unit do remain very strong.
That's great, Johnny. Thanks. Really clear presentation. Who wants to put a question or comment? Yes, Maria.
Morning. Thank you very much for your presentation, and congratulations to the team on, first of all, starting to look at engaging with children and young people around redesigning your services. That's a great aspiration to have. And also for looking at digging into the reasons behind what's not brought. I'm curious about something you said at the beginning around the rising numbers of patients coming in through outpatients and ED.
Yeah.
You said it's rising year on year, and I wondered, is that something that you're worried is not sustainable for your team in terms of resourcing? That's one question. And then you alluded to not really knowing the reasons why, and you linked it to health inequalities. I'm wondering if you have a sense of what is driving it. Is it that the population are sicker? In other words, do you think it's appropriate, the rising numbers? Are they appropriate or inappropriate? What's the clinical sense?
Yeah, I mean, I actually think children generally are much healthier than they have been, and so, with really successful immunisation programmes, the number of children who are severely unwell when they present acutely to hospital settings is actually really small, and it's a real challenge sometimes to identify those children. I think, though, part of it is that times have changed, and we worry more about our children. We want to make sure that they're well, and we have perhaps a lower threshold for children, parents bringing children for assessment. I think some of it is possibly related to access in terms of when children are acutely unwell. It can be difficult for those children to be seen in a timely fashion in other settings, in primary care or in urgent care, and they know, parents know that they'll get seen at NSET. We'll see them within 4 hours. We provide a good service by experienced staff, and they have that experience and they come. In terms of outpatients, I'm not sure. I think some of that is just a change in culture, and that we are accessible. We keep short waiting times, and a lot of what we see is for additional reassurance rather than for seeing children who have significant illness. So I think that's a large part of that. Sustainability, I think that's the real challenge, because it can be really busy, particularly in winter. We can have 80 to 100 children on the acute unit, over the course of 24 hours, which is a large number of children to see. So there is work going on around that. I didn't talk about it, but some of it is around the telephone deck phone that the consultants carry to try and redirect some patients who presented to primary care, to redirect them to urgent outpatients that we've started this year. And also some of it is around some of the pathways of managing sort of those minor and current illnesses, diarrhea and vomiting, abdominal pain, headaches, those relatively common things, managing them outside of an hospital setting. Those are the things that we try to do.
Thank you for that. Steve, and then Katie.
Really interested in the patient feedback, and I suppose in this arena we're talking about parent and patient feedback being really important. I was just wondering if there are any parts of your kind of busy, very diverse range of services that you don't feel are adequately covered with patient feedback, or do you think we've got a good picture of people experiencing?
I mean, I think we're not great at getting feedback directly from younger people, and the challenge in that is that, you know, after an outpatient appointment, I think a young person of 8, 9, 10 would be able to give some good feedback, but going through some of the forms that we have, a lot of it is inputted from parents and from their perception. So I think one of the things that we're really keen to do is get better feedback from young people themselves directly, rather than sort of reported from the parents. I think that's across the business unit, so across the different services. We do get quite a lot of feedback from young people in our mental health services, primary mental health workers and CAMS, so I think we actually do quite well in that bit.
I've got Alistair wanting to jump in before Katie, I think.
I suppose it was just commentary of Maria's comment, that I do wonder, my perception is that we have a lot of children who are seen both at NSEC, possibly in hours and in primary care. It's quite common to get 3 presentations per illness spell, and I think that reflects possibly coping within parents and extended family. But I wonder if we're going to do analysis, it might be, particularly if you look at integrated care, actually the number of touch points children have with healthcare rather than maybe the paediatric side of things, because if we're looking at it through an inequalities or other lens, I suspect there's enough escalation in all aspects, and it is quite stark the number of times there are multiple contacts with clinicians for the same spell that I experienced.
Yeah, I think that's really important, and I should have said that, Alistair, because we did have some feedback from quite a few years ago when NSEC first opened, and that was definitely the theme at that point, that patients had been seen in primary care but still wanted further reassurance, or the condition continued and a few hours later might come to NSEC, so I think that's entirely right.
And vice versa, actually.
Then I've got Katie, Marion, Margaret. Katie.
Great. Thank you for the presentation. It's really brilliant, very heartwarming, so thank you. Probably now I'm going to pick on epilepsy because I was absolutely delighted to see that we're expanding and seeing we have the highest epilepsy prevalence in the North East across the whole of England, and I think the more that we can expand our epilepsy nurse team to support that, I think really it's something very keen just to see how that expansion continues and how we're working with Newcastle technology in particular.
Yeah, no, that's great. I do the epilepsy work in Northumberland as well. It's really, it's a central part of my job to work really closely with the epilepsy nurses.
Johnny, if we can make sure that Katie's kind of kept briefed on those developments, that would be great. Marion.
Thank you. It was a very same comment actually about, I think it's great that the paediatric epilepsy nurses are able to prescribe and, you know, take away some of the children that you can only see, and that's great. The other comment was well done about the blind refer. I was there last week, and Ovisia's been out in our roadshows as well, and what a difference it makes.
Oh, yeah.
And I think that's really important to us for our patients, the users, the parents, etc., but also our staff. It's been a big thing, so thanks for keeping on.
Yeah, no, it's been really good development.
Margaret.
Thanks Johnny. First, great to see foods improving, but unfortunately we haven't got any results for this year, so it'd be really good next time to actually see that. So my 2 questions is around staff experience and looking forward to going to work. still doesn't look very good at 54.5%. And I just wonder what are we actually doing about that, because what you described was a really motivated, aspirational team that worked together, and you actually identified that there's pockets of great collaboration within teams and areas where there may not be. So it's just how we're going to improve that, because that isn't a good score in any shape or form.
No.
Let's take that one and I'll come back to your next question. Johnny?
Yeah, and so, well, I suppose I don't have a brilliant answer for that really, in terms of working on developing the team, engaging the team. I think it's all part of it. So there's been the separate teams that we have had away days as part of the sort of team development over the last couple of years as a regular programme, and I think that's an important part of developing the culture of the team, which goes in some ways to improving that particular point. Where there are areas of I suppose from some of the softer information that we have within the business unit, some of the other things that come through, whether our teams where there are challenges within them or relationships within teams which are particularly challenging. If we don't have that information from staff survey, we will do work with those teams as
Kate,
well.
do you want to add?
Yeah, just to, I think it's what Johnny said around it's one question within a few questions around engagement. And as you can imagine, looking forward to coming to work is multifactorial in terms of what people see, so that can have impacts on home lives, not just on work. So it's a very difficult question to really get into the skin of, so we see it in the round of the whole engagement score. Because I think we've got some, if I'm honest, we've got some really engaged people that would probably still say no to that question. Yeah.
Margaret, you had another question.
Yeah, and it's in relation to the progress that we're making in digital. So firstly, it is a shame that Badgernet has taken so long, because we have been talking about this for a while, and certainly in maternity services, it's working really, really well. So great that we're making some progress, but it would be good if we could do that before November. And then the second area around digital is around accessibility for young people coming to appointments. It'd be really good to know about young people and children and families' choice around how they access the service and what percentage are accessing it through digital approaches.
In terms of appointments or in terms of...
in consultations.
Yeah, so we don't see young people in their first appointment digitally, either on video or telephone. We always see them face to face, and then after that it's usually negotiated with the family and the young person about the follow-up appointment. Sometimes clinically you need to see them face to face, but otherwise it's that option that's discussed. So I think it's probably, we don't document it as such in terms of in that way, but it would be discussed within the outpatient clinic when they're first seen. We like to see patients, children anyway, face to face on the first appointment.
Yeah, I get that, and I think it might be useful to document, and I also think it might be useful to look at DNAs in relation to face-to-face and digital approaches as well.
So, and that is a bit of work we've done, and we're doing more of that this year. Yeah. So hopefully the next time we'll have a bit more info on that for you.
I think what will need to be the final two questions, Richard and then Lee.
Yeah, so Mark got there before me.
Okay.
A few of us went round ED last week and did a little detour through paediatric ED, and comments were picked up that felt the space was cramped, particularly during sort of early evening hours, which would be a busy period. Any thoughts on estate solutions that we can put on the shopping list to try and get space?
Yeah. I mean, it can be really busy, you know, weekends on Sunday evenings, during the during the weeknights in winter time. So it's something that the team recognise. The space is limited at 10 sec, but there's definitely thought being given to that and involvement in estates around that, and also development of an outpatient, of a room there for young people with mental health presentations and behavioural challenges too. That's another important thing to think about at NSEC. Yeah.
Very good. Ruth?
I just want to pick up on this CC4C point.
Oh, yeah.
So is it funded for very long, is my first question. Yeah, I thought that was because I'm trying to work out how we work out what benefits that has and if that does help divert people from ED or other services, if we try and push kind of frequent attenders. And so I wondered how long you had to actually try this out and see.
Yeah, so the funding was for a year for a pilot to get things up and running and started. The evidence base behind it is well established. For the CC4C, as I said, that's the London Model Imperial. It's just one of the models of the multidisciplinary community primary care teams that are out there. And they've shown overall, certainly in the London model, around a 13% reduction in urgent attendance at ED when that was in place, and a similar reduction in outpatient referrals once it was well established. So we've got involvement of the public health team here and the ICB in terms of, I suppose, evaluating the effectiveness of the implementation of the model in Northumberland. But it'll be a little while till we have information about that, because we actually have to get the pilots up and running started, and then we have to get patients being discussed. And I think it's more around developing those relationships with primary care and other services and sharing some of that risk and around patients and managing things in a different way, which takes time. But there is a plan for evaluation within it as one of the streams of the work.
That's great, Johnny. We've given you a good run. Loads of congratulations to you and your colleagues for all the positive outcomes. Some real interest in the rising demand and thinking about how we might start to find ways of turning the curve with that. Some really interesting discussion on feedback from children, which I might be encouraging Joe to tell us more about in due course and to reflect more. It's quite a science, getting the views of children in a way that is supportive for them and meaningful for us. It's not an off-the-shelf solution, but something I know you've got some real interest in. Lots of encouragement for the epilepsy work and expansion. Lots of encouragement for the refurb work. We're seeing a charity later on today, and I think we should. It's nice that we've had some really positive examples of the charity's impact. Recognition that staff experience, we've still got some work to do. Never an easy area, but we all kind of know that happy staff are much more effective. They make for happier children and families as well, so the more we can move on that, the better. I know we're working hard and fast on digital. The normal request to move even harder and even faster is not too surprising. Let's hope estates can find an instant and cheap solution to the space. I'm not holding my breath on that one. And just kind of finally, the issues around connected care for children, it's back to those principles of integrated collaboration that is at the heart of what some of the discussions that Bijou and colleagues are starting to move on, and to find a way of reshaping the way in which we do some of the frontline services for children, maybe back in picking up some of the lessons that some of us remember from 20 years ago, and it'd be quite nice to see that circle turn and come back. So that's been great to hear from you. Thank you very much indeed. Thank you, colleagues, for your contributions. Send on our thanks, please, Johnny. Okay, we get too interested, don't we? And isn't that fascinating stuff? So we're already 15 minutes behind, but let's not worry. What does time matter? Comms and engagement. Ross.
Thank you, Chair. I'll try and get us back on track a little bit. So as you can see from the dashboard, public sentiment and public trust in terms of the things we're doing remains really positive and strong. Having said that, you'll notice that both the needles on those are slightly less than they were in the previous quarterly report. Some of that, it was a tricky time in some ways. The service issues we had in January, AD access, waiting time things, all kind of added to that in January, but we have seen that steadily improve as we've moved on to the end of the quarter. Overall, still really positive and favourable, I think, compared to some of the national reputational and trust issues you'll have seen in the things like the VSAs. Loads of really positive highlights as well. Things like the Hexham refurb and the performance. We were named #1 by National Media for performance. Some really positive TV broadcast coverage of Berwick, construction work there where we'll have cameras inside, and also hopefully lots of you will have seen the feature we did with ITV where they came and met some of our long-serving volunteers and talked a bit about the importance of that. Worth also mentioning Community Promise, so Wayne Daly, who manages that for me, Wayne Daly and I went down to London to do a bit of a presentation to lots of other trusts about our work in Community Promise, and there's been a great deal of interest and real warmly welcomed on some of that, so I think that's an area, a real USP for us. Hopefully, again, it demonstrates how there's a real pipeline of positive stories around all the big signals, which is the way we try and shape and measure our work now. And I think the final mention just on some of the work, it's not captured in this report, it'll be in the next quarterly one, but some of the work we're doing currently for MPC. There has been a little bit of a change in that MPC now uses our central comms team to help deliver some of those messages, and we've just recently completed a programme of new branding and a new website, and some of that was mentioned in Governor and well received last night as well, so I'm happy to take any questions on the report.
Really good, clear presentation, thank you, Ross. Questions, comments? Happy simply to receive it. I love the videos, I think it's been really great work, and it's a really accessible way of reaching people, so thank you. Good, let's move straight on. Thank you for your collaboration on that. Health and safety, Stuart, we've got your standard report, and we've also got the opportunity to be briefed, Stephen, I'd say something, Stephen. We've got the opportunity also to be briefed on Martin's Law, the new terrorism prevention stuff. So over to you, Stephen.
I'll just quickly take you through the executive summary on health and safety. We've had 85 accidents incidents reported throughout the trust since the last report. All has been investigated, any actions put in place, have all been implemented. 4 of these incidents were video reportable. Again, they've all been investigated, there's no trends. So we're looking at any trend as we review these. Abuse of staff, we've had 165 reported. It's an increase of 21 since the last month. So we've put a dedicated group in place, and then out of that 85, 13 more than that have been sent out. So again, in the summary there's also a breakdown of the letters from areas except where they were sent out. We're currently drafting a trust violence reduction standard, working with others. And once this has been completed, we'll bring it to the next board for your review. We have updates on workplace and COSH risk assessments. We're sitting at 99% across the whole trust, which is really good. And it's only 1 or 2 missing, so again, we'll review that every week and send that out, which is really good. Internal audits, we've drafted the internal audit report, which we'll be doing over the next 4 quarters. And again, there's a breakdown of what we'll be covering. We've had audit 1, audit our fire safety and security, welfare at Seaton Dalrymple. Then we're reviewing their report, we're pushing back on some of the comments. So once that's been sorted, we've looked into that, we'll bring the reports to our next review in July. Martin's Law, again, we've got a presentation on there, so I'll take you through that once that's been completed. Fire, we've had 18 incidents reported across the trust in the last 2 months. No fire rescue attendants and no actions taken, which is good. We've completed 91 training sessions. We've trained 695 staff with 40 non-attendees, which is down to 5.5% again, which is really good. And the training in NSEC is 78%, and fire safety 1 year is sitting at 92%. Again, which is good training figures. So any questions on the health and safety fire report?
That's really clear, Stephen, and providing a lot of assurance. So who's got questions? Kate?
I don't have a question, just to add on the abuse against staff. So clearly it's a huge issue, and just I guess to assure board and public board that we are monitoring that closely via People and Culture Committee. Stephen's working jointly with Kirsty Shotton from a safeguarding perspective, and Stephen just mentioned there about the strategy which will come back in July, and we've also got a pilot that's going ahead on the delirium wards to just look at how we can manage that a little bit better and take any actions or recommendations that comes from that. You'll also see that there is a campaign around zero tolerance, and we are looking at, there was an action from last board around the alert system. So Stephen touched on the warning letters and how we can ensure that alert system goes further and goes across the alliance. The warning letters, it's difficult to know the impact they have, but they do make staff feel safe when they know that a member of the public is getting one of those letters. So just assurance really that there's still work to do, but it's on the radar of the subcommittee.
Strikes me this is the issue that always comes up first following your report, the kind of the sense of shock still that so many staff are facing incidents of violence, and we regularly do get assurance that we're on top of that and exploring it. At some point we just want to be able to see the tables turn and the numbers start going down systematically, but I know we're doing our best, and thank you. In due course we'll hear more from people. Other points people want to raise? Thank you, that's really good. Now Murphy's Law, this is a new requirements on almost every public body, and you've got a bit of a presentation for us.
Yeah, I'll quickly take you through this, yeah. So the Martin's Law, it's formerly known as the Terrorism Protection Premises Bill. It was passed in April through the government. So the law introduces a tiered approach, imposing various obligations on venues based on the capacity and size. The trust need to consider responsible persons under Martin's Law, which manage qualifying premises, which include our hospitals, healthcare facilities, could be GPs. Again, it's based on capacity and usage. I'll give you a breakdown of the so anywhere premises would hold 200 to 799 people. We must notify security industry authority, and also regular reviews, public protection measures, including evacuation, and then lockdown procedures. We do cover most of that now, but we need to make it clear within Martin's Law what they expect from ourselves. And the enhanced duty, which is over 800 people. So we must conduct a terrorism risk assessment and develop a security plan, document and provide a security plan to the regulator, and appoint a designated senior individual responsible for compliance. Again, we must implement physical security measures such as CCTV, barriers, access control, and again, levels of training depending on where staff are based. Sorry, one slide behind there. A new regulator will have powers to inspect and enforce compliance with Martin's Law, and non-compliance for the standard duty, fines up to £10,000, and daily penalties up to 500, which is 200 to 799 people. And the enhanced duty, for over the 800 people, we can receive fines up to 18 million, or 5% of worldwide revenue, plus daily penalties up to £50,000 if we don't have our risk assessments, etc. in place. So the operational adjustments, so we review and update our emergency procedures to align with Martin Law requirements, and ensure staff training programs are comprehensive, so there'll be TNAs, mandatory training, etc. We allocate budgets for implementing physical security measures where necessary, and designate personnel to oversee compliance and coordination efforts. In collaboration, we need to work with local authorities, other trusts within our region, engage in regular drills and stimulations and test preparedness. Again, we do a lot of this now, and a lot of this is already in place. We just really need to get the full law sense of it, so we know what else we have to do, if anything. So Martin Law represents a significant shift in public safety and responsibilities for trusts. We objectively address the requirements of the law. We enhance the safety and security of the premises. There's still a number of unknowns, and we are awaiting further information, clarification from NHSE. How do we qualify our buildings? So we've asked the question, is NSEC inclusive of the healthcare academy because it's on the same site, or is it going to be separate? So we get the numbers right, so it depends what category they fall in. And again, the recommendations we've come up with emergency preparedness, and my team, with health and safety and security, we take ownership of the implementation of the recommendations identified under Martin's Law. We set up a working group to include the Trust, NHFM and MPC representation to implement and monitor identified recommendations, and then we'll bring regular updates to the Trust Board on progress identified. So any questions?
Stephen, that's really clear. Any comments, questions? Stephen?
Thanks, Stephen. I think this was on the back of the Manchester bombing
Yeah.
wasn't it? And I think it would be good that it is linked in with our emergency preparedness team. I guess there's something as well in there about working in close partnership with the local police,
Yes.
in particular with combining some of our training exercises with them. So I think it would be good to see that play out here, but also on some of our other sites. So you'll remember the Rothbury lockdown situation that we had a good few years ago, which was probably our first and only foray into this area. But I think doing it on the other sites as well would be really important.
Yeah, we have a monthly meeting with the police at Minimum Police Partnership, so and again, this is on the agenda with our meeting.
Marion.
Yeah, thanks very much, Stephen. Just regarding the EPRR, I was very happy to work with you, and Alison and I, from an EPRR perspective, went to the Magic Light training a couple of months ago, and this was very much the topic of conversation following the Manchester incident. So I think that's put us in good stead to go forward.
Very good. Well, it feels like we all endorse the idea of putting this through our emergency preparedness group work with health and safety. The working group, clearly, but add the least to the list, regular updates. It would be a natural item 4.3 on your health and safety report, rather than a separate standalone report that's embedded within there, because you only need to tell us stuff when we need to know it. That's really good. Are we feeling informed? We understand the requirements on us as a board. Thank you, Stephen, very much for doing that. That's great. Good, then we're into net zero. We've already been congratulating you and colleagues in your absence, Claire, about the public sector decarbonisation funding between ourselves and Newcastle. But here, your opportunity to update us on the Green Plan and the refresh. Over to you, Claire.
Hi everyone, apologies because some of you heard this already yesterday in EMT, so a little bit of repetition. So essentially I'm here for 3 reasons. To gain approval for our Green Plan refresh in line with mandatory reporting requirements of NHSE, to give an update on the carbon budget, which was asked for last time I did the biannual update, and a very, very quick run through of our highlights in the last 6 months. So I'm going to spend most of the time on the Green Plan refresh and carbon budget. The Green Plan refresh is essentially, it is very much, as it says, it's a refresh. So we did a lot of work when it came to putting together our Net Zero Northumbria Action Plan at the beginning of 24. And the approach outlined in the NHSE guidance is seen on the slide. Essentially, we did this when we did Net Zero Northumbria. So it's very much, we've condensed the plan that the Trust published in 2022. And it's the updated plan that essentially, the only big difference is that it now includes smart actions and metrics and KPIs for reporting and monitoring going forward, which we just couldn't add when we did Net Zero Northumbria, because the data was either just not there, or we had some kind of, we knew that it wasn't very accurate. Now that we know that the baseline data is correct and our measuring and monitoring is done, that is now added to our plan. So we would like approval because it needs to be published on our website by the end of July. So the plan that we've produced has been circulated and socialised within North East and North Cumbria Provider Collaborative, and any feedback that we got, we incorporated. But actually, it's basically the kind of the cornerstone of all our net zero efforts going forward, and it will be in place until 2028. When we update Net Zero Northumbria Action Plan next year, we'll just make sure that the 2 documents are intrinsically linked. So they've currently been separate, but we'll make sure that they are one document going forward. So when I came here in November, it's gone very quickly, you asked us to have a look at our carbon budget now that our data was correct. So essentially we've modelled our carbon budget from our baseline of 2019 and 2020. And we've modelled it against, well, using the Tyndall Centre methodology, which is the accepted way of producing a carbon budget. You can see that the bar graph has 3 different colours. So scope 1 and 2 is, scope 1 is the gas that we use, and scope 2 is our electricity. As you can see, it's starting to stabilise, and we're starting to see the efforts, the kind of the fruits of our labour when it comes to reducing buildings' carbon footprint. The blue part of that bar chart is essentially what we buy. That is our supply chain. As you can see, it is increasing hugely.
As we would expect, we are buying more things, especially since the pandemic. This is where we now need to start really making our efforts towards reducing the carbon footprint. So we've got some really good stuff going on when it comes to buildings, but now we need to start really working with our suppliers. Our suppliers' scope 1 and 2 carbon footprint is our scope 3 carbon footprint, essentially. It does include other small bits, such as waste, which is essentially part of that scope 3, but it's tiny in comparison to what we buy. So essentially, from our 1920 baseline, we would have had to reduce at about 12.5% per year to get to our targets. Now we are essentially 51,000 tonnes over our allocated budget, if we think about it in a budget term, and we need to basically do a year-on-year 24.5% reduction, and the majority of that is to do with scope 3. We have significant plans in place for our buildings, and we've been rolling out projects. As Paul alluded to, we've been very successful in PSDS with the 3 projects that we put in for approval have been approved, which is great. And I'll move on to that now, but we'll touch upon the buildings again in a minute. So essentially a very quick run through. I'm literally going to pick one point off each key action area. We've got 8 of them. So from a corporate approach point of view, we've done very well. Thanks. We've won a number of awards. What we're doing has been recognised from a national point of view. From a people point of view, we've had quite a slow uptake in net zero e-learning. We would like to potentially make this mandatory, but not on an annual basis. This was picked up in our first Audit 1 sustainability audit this year, and action was to start to think about making that mandatory. I know Kate's going to be like, but we do need to think of a way that we can, because actually we get great feedback on it from the people that have done it. Our buildings and estates, so going back to PSDS application, both 3, NSEC, Wansbeck and Hexham were all accepted for decarbonisation, which is great. We will be off gas, essentially, there from 2028, so our plans are coming to fruition. At North Tyneside, finally, the air and water source heat pumps are now fully functional. We are off gas there, which is, we're one of the first in the country to do that. And all our gas and electricity supplies, and now with the CCS framework, have got far more preferential rates than we had previously. Waste and reuse, the big one is that we're about to mobilise the non-healthcare waste contract. We've been in contract with Northumberland Council for a number of years now, nearly 10. We've gone to competitive tender. We will start to mobilise that contract from the 1st of July, which will see a lot more waste being recycled, a lot of financial savings, and some much better data that comes in from our contractor, because at the minute everything is estimated, it's not weighed onto a wagon. So we'll see some really good results from there. Greening and adapting, we've just had our rewilding action plan for a number of sites back. That gives us a net zero, it gives us some metrics around biodiversity, so actually we can measure going forward what we're doing on each site when it comes to green space, which is great. Sustainable healthcare, the ED are working very strongly towards getting gold accreditation for this summer. Lots going on, including producing a climate adaptation plan for the ED. Journeys in Clean Air, we're about to start air quality monitoring here at NSEC, as we had approved this time last year. That programme has been put together by our F2 placement student that is between anaesthetics and public health. This is really great news, and we've got some really good data now when it comes to travel that we can actually start to measure modal shift. Supply chain, as we talked about, this has to be our key thing going forward. It's where our carbon footprint is, it's where the majority of the carbon footprint is. We're going to link up a lot more with procurement and Newcastle on how we can do a joined up approach with them, because their data is far superior to ours, because they've been working on it for a number of years now. And that is a very whistle-stop tour through the last 6 months.
That's quite clear. Thank you very much indeed. So let's take questions and comments before we go on to decide whether we want to approve the refresh. Alistair first.
Really positive report, and it's good to see it's all in line with the kind of deadlines we've got, but obviously a lot of work to do. I guess my question is, how focused are we on community and particularly MPC activities within this? And you mentioned things like the EV fleet, but particularly along the Alliance, for example, Gateshead are still doing pickups on every single site in Northumberland and North Tyneside. And we've got vans going there, so it doesn't really matter whether EV or petrol. Actually, we've got duplication across the Alliance footprint that would make a lot of sense to kind of reduce. So swapping to electricity is great, but actually reducing is probably more important. So I suppose those 2 points.
So the second point, for sure, one of the biggest portions of that Scope 3 blue chart is transport of our goods, and that's really probably where our focus needs to be, because it's kind of within our gift. Some of the supply chain stuff is not within our gift. We are dependent on our suppliers, so we are engaging with them really helps, but they have to make their Scope 1 and 2 reductions to enable us to see that in our Scope 3. So yeah, that's huge. I can't remember what your first question was.
It was community and primary care within the scope.
Yeah, MPC, we're working really heavily with MPC now on a kind of an action plan, similar to what we have at NHFM, because they're actually very, very keen. So we've got really good buy-in. We're going to have a workshop to develop kind of a short sustainability action plan for them that is specific to primary care, with a view actually that we could use that within the region to try and influence net zero at the primary care level, because net zero is moving away from the ICB.
And it's very good. David Hedgecock presented to governors yesterday and included enthusiastic wanting to be engaged, but recognition that they've got some catching up to do with the rest of the trust. Yes, Paul.
Claire, on the chart of carbon emissions, I think you used 1920 as the base year. I just wonder, probably outside of budget, I'd just be interested to see how much of that's driven by an increase in our estate footprint, and how we're performing from the buildings that, the sort of historic buildings that we've had, because I just want to see whether we've become more efficient on the buildings that were in the 1920 baseline. So, for example, the factory we didn't occupy the factory until after that date. And it would just be interesting to see how we're doing in terms of bringing down emissions through the historic estate, and how much our new estate is added to the.
And that's on the agenda for EMT, I think, on the 18th of June, potentially.
Good that that's been discussed, but the reality is we still have a carbon footprint for the trust. And if we have expanded our estate as we have, then we just have to adjust our targets.
We do, and that is taken account of in smart carbon.
That's what's important, just trying to drive at how much more efficiently we're using it in that sort of historical state.
Good point, Richard.
So first of all, great progress on Scope 1, Scope 2, and you can see half of that, which looks really good. I was also pleased to see on the first example, I guess, of taking the single use out and replacing with reusable. It feels like the tip of the iceberg.
It is the tip of the iceberg.
A lot of clinical practice is going to have to change. So I'm interested in what the engagement's like with clinical colleagues, recognising, because they don't use single plastic without good reason, but it's going to need a major change in thought.
The engagement with clinical colleagues is amazing, actually, I'll be honest. The trust can't go as quick as the clinical colleagues are telling us, actually, this could just be reusable. I think we just can't keep up with, there's things every week that we are changing to reusable. However, in the grand scheme of what we buy in, it's very small, so we need to work with procurement to see if actually we can do that a lot quicker and a lot more effectively. But then suppliers are offering us, this is a really big agenda for them, so we are getting suppliers offering us various things, but they then need to be tested clinically, don't they, to make sure that they stand up. So it's an issue that every trust has. It's just a
In Jeremy's absence, can I ask either Simon or Alistair as to the kind of the mood in the clinical teams as to how important this agenda is for them?
Simon will comment. So I think it's really positive. I mean, it's actually, we know in terms of particularly young doctors coming to work for us, including consultants, it's a big driver for them in terms of choice of destination is the Trust's approach to net zero. So it's a really strong motivator both to come and work for an organisation, but it's probably a generational thing that I think the younger generation is much more switched in, particularly medically, to this than perhaps an older, which is great. So real enthusiasm.
Simon?
Well, I agree completely, and lots of muttering about waste when they've got packs of things they're not using and a great big thing, and they're chucking most of it away because they only needed that part of it. There's some practicality to that. They want all the kit there, but they just see lots and lots of waste.
Very good. Marion?
And just to add probably the nursing and the side of things as well, the students that we get that are absolutely straight onto this and questioning us why we haven't done something. So obviously it goes to Claire and her team, and generally it is either there or it's in the pipeline. So I think it's really, really good work.
Okay. Well, I'm hearing a lot of enthusiasm, continued enthusiasm, which has been pretty consistent for the board for the work that Claire and her team have been doing. More to do in primary care, but we're on the case, and we're encouraging Claire and colleagues to be working with NPC, recognising there should be some easy wins in transport. I know it's on the agenda, important to keep it on the agenda. There's some bit of data allows us to work out whether we are improving our efficiency in the estates, because the estates have changed since 2019. We've heard of strong support from clinical medical colleagues, and recognising it actually has a positive HR benefit as well. It's a recruitment and a retention plus that we are taking this seriously. Overall, the biggest area for potential gain is the decarbonisation, and we're now potentially properly on track for that. It's a bit dispiriting to see the Scope 3 and how difficult that's going to be. So I think we welcome the collaborative work you're describing. But I'm looking to see if we're all ready to approve the refresh. And I'm seeing lots of nods around the room. We're approving the refresh. We're thanking you for your update, and more power to you, Ella. Thank you very much indeed. I'm going to suggest a 5-minute comfort break. It's 10 past now. Can we start again at 4 past? Thank you very much indeed. Right, colleagues, back in business. Second half. We're into it. We've got a couple of annual reports to receive. First of all, the Emergency Preparedness, Resilience and Response Annual Report, Marion.
Yes, thank you. Thank you, yes, and you all read the paper, and this is our annual report for EPRR, Emergency Preparedness, Resilience and Response. There's been a significant level of assurance, and it meets all our statutory requirements. There was just one or two things I just wanted to add that are already in the report, but just to flag. The EPRR team now are fully staffed, delighted that's on our risk register last year, delighted, and we've included an apprentice in that role, which has been very well received. Alistair and I, between us, go to the health resilience committees and the local one as well. That's been really, really good, learning a lot and making sure that we can give and share information to the rest of our team. There's also been a lot about health commander portfolios that, as a senior team, we must do. We're actually leading the way in the North East at the moment with this, and Alison and Lauren and the team have been great at making sure that we all complete these. And we have been asked to share out how we have done that to other areas. You can see in the paper there's been training throughout the year. We're specifically looking at training that's cancelled and to make sure that we can reduce that as much as possible. And then the two final things are just about changes in the staff this year, or within this report. Bernie McCardle was our chair till the end of October last year, and delighted to say that Margaret is sitting next to me. Margaret Rowe is our new chairman from November, and we've put in a new post there, which we haven't had before, which is a clinical lead, who is Claire Garland, one of our orthopaedic one of our ED consultants, who is very much living from a clinical angle, and that's been really, really helpful. Happy to take any questions.
Thank you. Margaret, do you want to add a flavour? Having been chairing it for 6 months now, 5 months, thank you.
Thanks, thanks, Chair. Yeah, it's been really interesting to work with the team, and fantastic that they are fully staffed. We've got a number of exercises planned going forward around pandemic, preparing for pandemic. We've got the Azuma exercise in June, which I'm really looking forward to spending a day with the team. And there's a number of things that we are looking at more closely. Certainly the deep dive on cybersecurity in relation to some of the activity that's been going on within the Trust is high on our agenda, and we're constantly looking at different approaches to managing some of the direction of the work and sharing that work.
Thank you very much indeed for that. Any questions or comments from Marion or Margaret? We're happy to receive this report with thanks. Thank you very much indeed.
Thank you.
And the next one, this is the longest report, but possibly will take the shortest amount of time because the quality account has gone through lots of iterations and through several committees. Melissa, there's been loads of work going into this.
Yeah, so this is the final draft version of the 2024-25 quality account. So it went to Safety Quality Improvement Committee on Friday for approval, and then it's gone to our stakeholders for comment. So we're expecting that back. But anyway, it's going to board for final approval on the 27th of June, sorry.
Okay, so it comes back to us for final approval, but it's been at SQ&I. Maria, any comments and reflections?
No, very good progress made, especially against the safety the priorities from last year. A couple of them carried over, but very good progress overall.
Thank you for that. Any comments on the quality account, or are we ready to receive? We're not being asked to approve it at this stage. That will be next month's task, when we'll be something like the fourth time we've seen it, I think, but it's different iterations. Good to go? Thank you very much indeed. Then we're on to patient and staff stories. Quite a challenging one this time, Joe, but if I say I'm pleased about that, I mean, to remind colleagues, we tend to slightly alternate through here. We have some patient and staff stories that give us a really positive story that makes our hearts glow, but we've been very encouraging of bringing in those stories that we all know exist of where things haven't gone according to plan to enable us to learn from it. So Joe, thank you for bringing forward this somewhat harrowing read on discharge planning. Over to you.
Thank you, Chair. So just a point of note before I go into the stories. So the patient in particular, this is part of a bigger patient experience that has been shared, and I'd just like to thank Marion and Elliot Sykes and the senior nursing team in surgery who met with the patient to talk through their wider experience and some of the actions that came from that, but also this was one of the actions that we would share this aspect of their experience as a forward story along with their wife. So as you've already said, both the staff and patient and family member story relates to the discharge process. I think what this highlights in particular is around the importance of involvement of family members. So what the lady in particular describes is she uses a line within the story that is informed but not involved. So receiving information but really understanding the what and the why. In relation particularly to the medication that she was managing and overseeing for her husband and the equipment that he subsequently needed after the surgery that he received after having an accident. The gentleman concerned also, as part of the story, he talked from a positive aspect. He talked about the inpatient letter that he received, and I know we talked particularly in relation to the patient charter. That's one of our principles, is information and letters that are addressed to patients and are accessible in terms of the language that we use. And he talked about the inpatient letter being very good and easy to understand, so I thought that was a really positive aspect to take. And also the efficiency of the equipment arriving. So maybe not so much about understanding how the equipment would be used, but the efficiency of that arriving. And he also talked about the physio and OT intervention that happened on the ward was particularly good, but that information about who to contact if you had any worry or concerns was lacking in particular, so that involvement side. So the staff story is very much in response to the patient and family story, and it comes from the Deputy Head of Nursing for the Surgical Business Unit. I think it's a very comprehensive response. The team as a whole, from the ward and the wider team, welcome the feedback, and it has been shared by way of learning for the team. I think she very much seeks to give assurance in terms of detailing the whole discharge process, the MDT approach that's adopted on the ward. I think where this story may differ slightly in terms of is the family member, the patient clearly has capacity and the information was shared and discussed with the patient. However, the lady wife took on the care and responsibility for the husband's recovery and wasn't involved in that process and didn't have the information. So yeah, that's probably where this particular experience has fallen down somewhat. I think from an assurance perspective, the Deputy Head of Nursing talked about some of the improvement work. So I know in particular, because I've been involved with Sue Hewitt and Kay, from the medication checklist that's been developed, and actually involving our staff in that to feedback on how that feels, and obviously that is part of the discharge process. And I know Sue Hewitt is leading a wider piece of work, and I'm just meeting with her on Friday actually to talk about how carers are integrated and involved in the discharge process. I think she also highlights that patients, quite right in the fact that patients have not been consistently given contact information, although it's available for OTs and physios, and she gives us guarantees within the story that the team will make sure that that happens going forward. So I think, yeah, as you say, there are some parts of the story and some that is not what we would want for our patients or their families, but I think also on the reverse there is some improvement work, particularly in terms of the ward and the learning, but also the wider strategic approach. And just the other thing I didn't mention is we've actually written a section on carers and a link to the carer checklist to go into the new discharge policy for the trust, which is still to be ratified.
Joe, that's great. And just before I open up, I think we should be thanking Debbie Whiteman for her willingness to respond and the way in which she's clearly not trying to simply kind of say rebut everything, but openly consider what learning has come from a case like this. But I think that's a good example of how to respond to criticism, to use criticism as a gift to improve. Comments, questions? Who would like to come in? Bijou.
So I think board already knows that discharge is one of our safety and quality priorities this year. Clearly, it spans a whole number of things, and we'll have to take this piece by piece as we try and kind of unpack how we improve that whole process. I think there is something as well, isn't there? There's the process elements and then there's the people elements of discharge. And I think some of the people elements, you can see and understandably on a busy ward, we make a whole number of assumptions about the people who happen to be in front of us. So particularly when they have capacity, particularly when they might be articulate, particularly when we assume that they have a family network around them, that we might not ask some of the questions that we would ask others. So we make a whole number of it, and you can see how and why it happens. And there may just be something to consider, and this is probably not just about discharge, but a whole wider array of that early engagement, which might feel a bit basic about how we want families to be involved and how we want the patient to be involved in some of the decision making, in some of the I think the gentleman made a really valid point that he thought he would be okay, but after the first 24 hours he realised he wasn't going to be okay. And I think that, and I know we've done it on a couple of wards and we do it electively, that post-20, and I recognise we can't do this across the board for all of our admissions and discharges, but that post-24 hour, are you okay call, is there anything that doesn't work for you? Because it works really well on the elective pathway, and I just don't know whether we can find a way of doing that. That bit really resonated, because we thought it would all be an okay discharge, and actually it was only after the first 24 hours that it played out and it wasn't so good.
Very good. Anybody else want to come in? Okay. Really good that we've had this process, really good that you're following it up. Fortunate that we already have a vehicle for taking this forward through the work on the safety, on the priority, one of the priorities, which means that I know Safety and Quality Committee will be looking at it as part part of their normal process, but in doing so, they'll take into account what's come forward today. And I think Biju's point about separating out the process from the people and thinking about what sometimes it actually means in terms of the person. It's really hard to measure this, and it's really hard to get it right all the time, but it's quite a good guideline for us. Thank you very much indeed, and make sure, please, Joe, that you pass on thanks to Debbie and indeed to the family themselves. Good, then we're into the patient and staff experience report. And if I say there's nothing much new in this one compared to last time, is that a fair comment?
Yeah, I would agree.
Then bring out what's important for us.
So just starting with Patient Perspective, which is our third-party provider who carries out a number of surveys across inpatient, day case and outpatients. I think we continue to see strong performance when we look at the rating of care that patients give us. So that's people who rate the care as good, very good or excellent. So we see that across the three areas. If we look at inpatients in particular, and we look at performance over time, we are continuing to see a decline, although we remain in the top 20% when we can benchmark ourselves against them nationally. I think particular point to raise is NSAC in particular, so they are falling below the 20% threshold for the third data point in a row. And the areas in particular that are highlighting for focus are waiting for a bed once admitted, discharge planning, which we've just talked about, and the involvement of families or important others, and pain management and hydration. And that's for the second quarter that hydration has been highlighted. When we look at emergency care services, we remain in the top 20% for 22 out of the 27 questions that are comparable with the national survey. Our SPC charts demonstrate a historical decline now, over 16 points, and NSEC again remains below the threshold, which is 78%. And the areas for focus in particular are the ones that I've brought before, which is waiting times, pain management, and the information that we give. And that's 7 data points in total that we're looking at when we're looking at that time. Conversely, if we look at the real-time measurement that we do within the emergency department, as Biju said before, we've seen some improved performance, so that's when we call patients around 48 hours after they've had a visit. In particular, we saw 2 domains that improved, so they were statistically relevant in terms of their improvement. It was waiting times for April, and the consistency and coordination of the care that patients received, and that's when we compare to the baseline of 2024. When we look at inpatient real time, again we continue to see the strong performance that we see across the real time programme. In particular, we see a statistical improvement with food. I just wanted to, I know we talked about the children's unit before, I just wanted to give the board assurance that in 2025, all of the scores have been comfortably above 9, so it's great to see that performance in terms of the improvements they've made to the menu there. When we look at our community services, so what we do there is we look at overall satisfaction and very good performance, so just under 95% where patients rate their experience as very good or good. And the things that have mattered most and they report highly on is the kindness and compassion that our staff show to them when they're receiving care, also the staff themselves and the quality of the service they provide and their professionalism in doing that, and access, which again, really important areas. So when we look conversely, it's just over 2.5% of patients who rate their care as either poor or very poor from our community services, and that relates in the main to waiting, the communication and information that we give, and the coordination of care. Our social media analysis, so you'll know that we use the PEP Health platform, which is an AI platform, and what it does is it analyses all of the external reviews that patients do on Google and NHS Choices. And I think we can continue to show consistent performance there, so our score is equal to that of the region, and we're 0.2 above the national score, so we continue to hold our own. And you know, I always say to the board that that's patients talking about what really matters to them and not asking them questions, so I think it is an area of focus and importance for us. Moving on to our staff experience, so we just come out of our local staff survey in April, which also includes our health needs assessment, which we run on behalf of our public health colleagues. I think there's not a big story to tell in terms of if we compare between January and April, there's no statistical difference either at the 3 average score levels or a question level. However, I will point out that 2 of the highest scoring questions within the April survey related to how staff feel about the care that we give to patients and how we support families, so I think that's really important. And just to add in terms of, we've talked a lot today about improving staff experience, particularly with the Child Health Business Unit, and our subsidiaries and business units have all just received their dashboards for spring, which gives them a whole analysis of those local staff surveys and the national staff survey from this year. And there's been some absolutely excellent discussions about improvement actions for the year ahead. I will say celebration of good practice as well, because we should never lose sight of that. And all of the business units and subsidiaries have an action plan for the year ahead in terms of how we will focus on the experience of our staff.
Great presentation. And I should just say that the fact that there are not enormous changes from last time is a sign of the credibility of the data rather than the criticism of it. Although I will just say what would make the report 9.9 instead of 9.8 would be a little section in the summary that says what's changed, just to highlight the 3 things or the no things or the 8 things that have changed. Terrific stuff. Bijou.
Yeah, just a couple of points, Joe, on the patient experience. So appreciating that the NSEC ED is below the threshold, but I think I'm right when I'm looking at the graph that I'm taking a little bit of comfort is that we're not deteriorating further. We seem to have steadied now, and I'm hoping that actually we'll start to pick up again. And that part of me would want to say, I think that the real-time measures have really helped in terms of being able to focus the ED effort. I think we heard at FIP last month about how we've got senior nurses that have taken each of those domains and quite seriously, because I've seen them do it in the department about how they're going to improve on each of those domains. So hopefully we'll start to see that shift. And then I think the other thing which you've alluded to, and we've talked about this quite a bit, we've shared it with governors, we've shared it on the staff roadshow, is time, and how time and valuing time and waiting is really important to our patients. And I think that is a big driver this year for us across the organisation. It's not a 1-year thing, it's one of the things that we've said when I talked to the Chief Exec dashboard at the beginning about the focus being patient, staff and improvement. One of those big improvement measures is around valuing time. So hopefully again, I think your patient experience data also correlates with what the staff are telling us and correlates, which we know is in some of our performance metrics, which are all measured around time. So hopefully all those 3 things will start to come together. I don't pretend that will all change overnight. We have to understand that's the long game that here we're going to have to play.
And I think also, Bijou, just to add to that, is the patient charter. That's one of the key principles within that, is valuing the time and making best use of patients. So, and we're just about to do a baseline measurement across our patients to really understand that. So I think, it's in all aspects of care, not just easy.
Right. Chris.
Yeah, just on the ED real-time measurement, the waiting domain, I've always assumed that that had a real close correlation to the 4-hour performance, whereas actually between March and April, there's no correlation at all. The performance unfortunately went down just a wee bit, but the waiting has gone up by over 1, nearly like 10. So maybe it's actually, and I don't know whether then patients think actually is it the 4-hour standard that they judge around waiting and what they view of waiting, or is it something more different, or is it something around time for assessment, which did go down between March and April? So I don't know whether we can do a bit more, have a bit more understanding about what is it that drives patients to say that their wait was acceptable.
I think there's lots of factors. I think that the time factor.
When you sample as well.
Yeah, and it's feeling informed and knowing what's going to happen. So I think it's about experience, isn't it? So I think there's absolutely the hard metrics about how long did I wait, but there's also that how informed was I that what's going to happen next. So if you know what's happening next and how long that wait will be, people are, I'm not saying accepting, but they feel more involved in the process than just sitting. Because I think, if we talk about the real time and how that's driven improvement in ED, the screens, it has been as an output of the feedback that we got from patients around the the manual board. And if you read through the comments in the report, patients talk about the value of having the screen over and over again. So I think it really matters to people that, yeah, nobody wants to wait for a long time, but understanding why you waited and how long you'll wait will be part of that experience as well.
Simon.
Sorry.
I agree, and I just want to explain that. I think it's way relevant to the end point. So I think, unfortunately, when that building's under the greatest pressures, it's the least, the lower security patients that wait the longest. And so if you come in and somebody just sees you in 5 minutes and says, no, it's not broken, you can go, but you waited 5 hours for that, then that is unacceptable. You know, why would you want to? But you can understand why that's happened, because actually they've been busy in recess with a car accident. So that's the reality, and I guess just to put a big circle, that's why the front door's been so important, because it helps sift out those people, and they get the same quick assessment, but they're getting it, you know, almost on arrival to the building, and they get to go home very quickly, rather than wait because you didn't really need to be here in the first place. But it will never have, if we have 10 out of 10 on wait in that building, either Joe's team have gone mad or we're doing it wrong. Because unfortunately in emergency care, wait is part of what we will come to expect. And prioritisation is key.
That's actually a good little measure, a good kind of reminder. Okay.
Thank you. I just wanted to mention staff experience. So Jo and her team demonstrated yesterday at People and Culture Committee an interactive dashboard for the results, which I think for the first time will enable individual staff members to go on the dashboard and have a look for themselves at what the issues are within their teams. We're working through how we communicate that and deliver that out to teams, and we had a good discussion yesterday at PCC about that. But that will create that ownership and responsibility of individuals as well to look at their own staff experience. So just thought it was worth mentioning that too.
That's great. Katie, anything you want to add on that?
Nothing further to add, but it was brilliant to see. So we're really excited just to start to get to use that and see the transparency with the teams.
How terrific is that? Okay, really good.
I was just going to say we're calling it a game changer.
Yeah. Any more on the patient and staff experience section? That's really good. Thank you very much indeed. Got some useful lessons on that. Some more thinking about what the issues really are behind the waiting. Clarifying a bit more openly and upfront what's changed month by month. Good. Let's move on. Now this is a new report, Maternity Safety Champion report at my request. So thank you, Margaret. We'll still test this, and I'll just get people's views at the end as well. I'm very conscious that within maternity we get a lot of formal reporting, quite rightly, because of all the scandals that have been nationally. The amount of data that we have to process is extensive, and my worry is that the risk that it moves us away from the feel of it. And since we have a maternity safety champion, Margaret, whose role it is to get underneath the surface a bit, to dig beneath the data, and I was keen for us to get a little bit more of a subjective, not so data-driven, just the kind of, so what are you feeling at the moment? What should we be feeling as a result of your experience? And this is Margaret's first report on it, so welcome that, but I will also invite comments as to the kind of other things, if there are other things you'd really welcome her telling us about in due course. Margaret.
Thanks, Chair, and I was absolutely going to say that because it is the first report, it would be really good to look at what is missing and what sort of things that you would like to see. Because obviously, as the Maternity Safety Champion, I meet with the senior leadership team on a monthly basis, but I also do regular walkarounds and talk to the staff. One of the things that struck me over the period of time that I have been a Maternity Safety Champion, it's very difficult to talk to the mothers and their partners because of the situations that they're in, and many of them are in assigned rooms, so it is difficult to get access. And what this report doesn't talk about is some of the communication approaches that I've used on the maternity safety unit, and that includes my poster around what is the role of the maternity safety champion is in each of the areas, plus how to contact me. Saying that, nobody has actually contacted me.
But they could.
And it was interesting because there's an individual perspective. My daughter was on the unit just before Christmas, and I was a bit surprised to suddenly see her mum's picture all over the place, and therefore I wanted some individual feedback from her. So that, and it was very, very positive. So just to say that is quite difficult, but I'd be interested if you think that is an approach you should be taking to find out and work with Joan how to take that. So I am going to just take this as given that you've read this, and just to sort of highlight a couple of things that I think are really important. We've been talking about for quite some time the importance of women having a choice and women having a voice, and but the issue is it's risk and safety, and particularly what we found in the community is at times some of our midwives have limited birth numbers, and their levels of competence need further enhancement and training, and it's fantastic to see that the unit is actually doing that. And while I was doing the most recent visit, I did meet with a number of community midwives and talked about the training that they were doing and talked about the importance of being able to attend. We know that North of Northumbria have really struggled in doing some of that training and have been slow to adopt to some of that training, and it's going to take some time. Hence why we have that area out of commission for birth at the moment, and it is going to take some time to do that. It was really good that the Labour Ward Forum started again, and this was a forum that is led by the matron on the Labour unit, but it hasn't actually occurred for quite some time, and I had been pushing about the importance of colleagues who are on that unit to get together and be able to discuss what some of the challenges are going forward. We've also been talking about a change to the leadership in relation to maternity safety, so having individuals who are the maternity safety champions in each of the areas who work with me and we meet on a regular basis, but also the leadership quad, which is the lead obstetrician, Katie Barker, Sangeeta, who's the lead for Skaboo, Katie Lishman, who you know, who's the head of midwifery, and we've got a new general manager, which is Dave Kingsley, who I've only met once, and I've got another meeting coming up with him. So looking at some of the strategic changes that we need to do. As I walked around, it was great, because I've always talked to a multidisciplinary team on the unit, and there was a number of asks, so I decided in this particular paper to identify what the asks were, because with the Birth Rate Plus funding that should be coming in shortly in 2025, we should have some extra funding, and particularly in relation to hydration and feeding, because what we've seen is a number of breastfeeding rates nationally going down, and that we do need to encourage some individuals, and particularly it can be very challenging. And we've got some fantastic exemplars of services within the unit here. But I think there's still, we should be aspirational about what can we achieve and move forward. So that's why I identify what some of the asks would be. So I'll open to 10 questions.
Thank you, Margaret. Anybody want to put a question or suggestion or comment? Ruth.
Just to pick up on one of your asks, really, Margaret, about the breastfeeding support, because we have tried to link up. There are quite a lot of community support things, and I've spoken to Katie about linking up with a project that's in North Tyneside, where I think if we're talking about hospital to community, they're the kind of things where there is a network there, and we've got to be better at pointing people in the right direction, because we can't, they're with us for such a short period of time, we really need to link up those services. So I think that's just about us being a bit cleverer about pointing people at things.
Good point, Mary.
And I think on that point we have to be mindful about the health visiting role in all of this.
Yes.
Because like I said, 20 days transfer over to the health visitors who have got them for the rest of their lives really, and about preparing them for perhaps another child. So we're trying to work in there, you know that the health visiting service isn't with us, it's with Harrogate, but actually there are no problems there, it's just making sure, as Ruth says, we know where the networking is and making sure that communication is open and available.
Great. At the moment I'm asking Margaret if she can produce something like this quarterly. Does that feel about right to people? We don't need it every so. Are you happy? Are you pleased with it? I think this is an important addition to what we receive. So, Ruth.
Just raise one other thing. It does say that the birth rate hasn't reduced with Newcastle reopening, which is quite a shock because I think everybody thought we would see a big decline.
Yeah. So it's something that I've triangulated on every visit, just looking at what the birth rate is, but also retention of our staff, because I was quite worried that we might see some changes, particularly with the leadership of Newcastle Maternity Services originally working in this unit and has quite a high profile position. And what we've seen is that hasn't occurred, that the midwives want to stay within the unit. They're quite satisfied, they like the approaches. Yes, there is stressful challenges because of the recruitment, but we've done really well in the recruitment over the last year, and there is real pressure rises on that. And what the discussions have been is that women are choosing still to come here first because of the service and because of the reputation, so that was really good. But we do need a watching brief. And when I went over to Gateshead Services, which do very well from a satisfaction level, it was fascinating to see just how good we were, I felt, and what our environment was, and looking at the aspiration for change and movement of some of the direction in relation to research, in relation to skill development, and I just felt we are doing incredibly well. There's always more to do, but I definitely felt that. So I will always keep coming back to those questions. But yeah, I think it could have been a challenge, but doesn't seem to be.
Yes, Mayor.
Thank you, Chair. Thank you, Margaret, for the report. The thing that stood out for me is the safety element, that the staffing ratios are safe, because we've been talking a bit in recent months about challenges around competency, as you quite rightly highlighted, in terms of skill development, but yet the staffing ratios are safe and met all guidelines. So that's provided a good level of assurance.
Good, indeed. Well, that's Marion.
Sorry, just one final point. We are, as Margaret says, we really are looking to see, North East wide, about where people do deliver. I think we are finding though that there is a bit of a plateau in the birth rate at the moment, and we're just really monitoring that. And we also are, because we've mentioned before, Newcastle have reopened their birthing area, and I think that we felt that we may get a drop in attendances from us. It's sort of plateaued, but we are not getting the people that are coming in as late bookers now, because I think Newcastle have absolutely got their act together regarding where they want to be with the people that go to them. So we just need to keep an eye on that, usually about the birth rate, which we are.
Very good, very good. Then let's move on. I think we're ready to move on from that. To board walkabouts. We've got two this month, and one of them is Margaret wants a game at Cobalt, Northumbria House. Look, too many major things to bring out of this one, but anything you want to highlight, Margaret?
No, not really. It was great. The staff, I met a lot of staff. You pushed everybody in, which was fantastic. But and what was good is Ross wasn't with me at all times, so I did have lots of one-to-one and lots of groups. I did identify, and they were brilliant. All the staff were really enthusiastic, really positive, and open about some of the challenges. Because the environment was slightly different in different teams. Because some teams, I think, were clearer about what they wanted, and others hadn't been. But now that they could see what other teams had, was suddenly now there was an ask, which was great to see that they felt confident to be able to ask that. I thoroughly, it was a quick visit, but spending time with Molly and looking at the work that she was doing, I thought was excellent. And where a lot of organisations are buying in from businesses and companies to develop that sort of activity, to have somebody in-house who could do this, but also look at how we could income generate from her activity and share knowledge and experience across the lines, I thought was really, really good. But it was a great visit, Ross, and I really appreciate your time and your other colleagues' time. I couldn't write everybody's name because there were just pages and pages seeing everybody.
Well, that's really good. Questions or comments? Nice to hear all that. Richard, you in Ward 3, Ward 9?
Yeah, fascinating visits.
Deceptively calm.
I could spend the rest of the morning unwrapping this one, but it was very interesting, both the acute medical wards. It felt timely to go see them as we were coming out of the very high pressures of winter. Also very timely because at the last board meeting we saw the levels of staff abuse, particularly in Ward 9, so it was very interesting to follow that one up, and we also had some concern there at the time about observation of falls. That particular one, they answered the question before we asked, they gave us the answer before we asked the question. There was a very high level of acute awareness to the risk of falls within the wards, which was very good. Fascinating talking to the F1 doctors, first week of their new rotation. Whichever wards they'd come from, they'd suddenly seen a massive increase in pace going into wards 3 and 9, which I thought was quite fascinating. They all loved the place, and it's particularly interesting to hear the one who'd come across from Liverpool to deliberately get a different experience and clearly really enjoyed the results. So that I think was all great stuff. Jeremy went off to have a long talk about the treatment of patients from St George's in our trust. I think he's very pleased that there was good join up. I think if he was here, he would just ask the question whether that's the right way around, having St George's staff supporting our colleagues in our ward rather than our staff supporting St George's staff in their ward, and whether that's always the right way of doing things. That left me quite a bit of time to talk to all the other staff on the 2 wards, and we talked quite a lot about abuse towards staff. Every single one of them had experienced it firsthand, either dealing with the wreckage of rooms that had been trashed, or having, in one case, having been attacked themselves. Very appreciative of the support they were getting from ward managers, people within the hospital. Just to question whether we're visible enough in the support we're giving as a board, in the messaging that we're giving, and I think there's something we could reflect on there. And clearly, it's probably just I've not thought about it before. I was very aware of the issues that we have in ED when the drunks turn up on a Friday night, and issues that you'd have in the NSOP wards, less probably aware of the impact that delirium can have if it's the wrong patient at the wrong time. And that must be in the very hard to fix box, so good to hear that we're doing something about that. But that whole feeling, it was good to be able to get the comments there, because it was very raw and very first-hand, and what I recommend to everybody to ask.
Thank you, that's really brought it to life. Kate?
Thanks, Richard. And the pilot I mentioned earlier with some of the actions is on Ward 9, so hopefully we can see some impact.
Good, good. And further endorsement of the value of these walkabouts. I know all of us do them, but just keep encouraging us all to do so. Questions or comments to Richard? And thank you very much indeed for that. We're into some of the governance bits now, and we've got risk appetite, risk management policy. I think we need to approve this, don't we? The agenda says to receive, but I think we need to approve. Chris, do you want to talk us through it? It's gone through quite a few places.
Indeed, yeah, thank you. So this is the risk appetite element that we bring back to board every year to make sure we've got the risk appetite on our several risk elements correctly categorised. And this is about how much risk the board are willing to take in order to deliver the trust's strategy. So if I just go to page 278 of the pack, I think that's the main bit just to look at and approve today. We've got the risk elements on the table with the risk appetite that we're proposing the board is comfortable with. So in terms of compliance, regulatory quality, we have a low risk appetite on those areas. Finance and reputation commercial, we have a moderate risk appetite, and then innovation, we have a significant risk appetite on that area. So as you say, Chair, that's just to hopefully approve today that that's the board's comfortable with those levels of risk, and we'll monitor that through the BAF.
And this has been agreed by FIP and also gone to audit, is that correct? Am I correct on that? You've gone through audit? No, it is.
We did talk about it in a board development discussion, didn't we? The only comment that came out was whether we were comfortable with moderate on reputation, which we discussed about in the round, and everybody got themselves comfortable with that, because the view was we sometimes do push at things,
Yeah.
and we're willing to look at that as a moderate risk. So.
Good, thank you. I've missed that item, haven't I? Thank you very much for that prompt. Then anybody got a point before I ask us to approve this? Katie?
Yeah, thank you. Just one point. I raised it with Chris yesterday. I'm happy with the actual ratings, but just thinking the categories, because things change, strategy change, and I'm not clear if these categories are set in stone or whether we need to just think through if we're covering everything. A lot of organisations have sort of cultural changes, a risk appetite category, people as a category. So I think the next time it's just reflecting on if we're comfortable with the categories we've got for risk appetite.
I see nodding heads from the people who are responsible for driving that thinking. So should we agree that we have a look at that for next time? There's plenty of time for that, but scratch your head a bit of benefit. We'll think about the alternative categories. With that point noted, are we ready to approve the risk appetite and management policy? Thank you. Board assurance framework. Chris again.
Again, just to bring this back to committee chair, just to note that we've undertaken a full review of all the principal objectives that will contain on the BAF in the next sort of 4 or 5 weeks, and that will involve colleagues from the COSEC team, as well as the exec director and the non-exec director of the board that the principal objective goes to, just to make sure that we're reflecting the work of that board, the priorities and the areas of concern of that board for the forthcoming year. So we'll obviously bring that back to the trust board for approval, not necessarily approval, but for ongoing monitoring. So that'll be happening in the next sort of 4 or 5 weeks. And also just to remind that the what's contained in the paper here has been back through each relevant subcommittee for discussion and approval and sign off. Just I guess maybe the couple to highlight, which I think prompt the most debate and discussion, is our favourites of 3.2a and 3.2b about the delivery of the oversight framework and whether that's the constitutional standard or the national standard. So that debate is, I think, categorised as live and ongoing.
Is that your subtle way of saying not everybody yet agrees with the way in which we've now formulated?
Yes. I think it's one of those where you could slice it either way and still be right. And maybe it's tying ourselves a wee bit in knots with it. And actually the fundamental is, if we as a trust continue to improve our performance and deliver against the softs, in some ways then the debate becomes
academic.
And actually that's maybe is where our focus really needs to be, rather than kind of trying to put a mechanism around not achieving something.
It's a simple way of field driving improvement, I think.
Yeah, it's much easier to get improvement rather than rewrite the path.
Okay, so noting it's not quite perfect yet, 3.2a and b, but it's not bad, and I think it is an improvement on where we were. Has anybody got any additional points that they haven't felt they've had the chance to raise, or maybe they raised them but didn't felt they were spot on? Anybody got any flags to flag? Then I think I'm asking for your agreement to us to receive the Board Assurance Framework. Thank you. And we're into another of these slightly formulaic things, the CQC Regulation 17, where we're asked to note that we're doing all the feedback stuff that we're expected to do. Ross, you seem to be giving us strong assurance on that.
Yeah, I think it's just really a formal version of what Joe and I have already presented in our separate reports. We're all fully compliant, and I can just present without any further comment.
Anybody got any comments or questions or challenges, or are we ready to receive the CQC standards? Good, thank you. We're into items for escalation from the board committees. So all these, of course, have been chewed over at board, but that doesn't at committees, but that doesn't mean that we can't further raise and highlight further issues. So let's start with the nursing and midwifery staffing and assurance support. In some ways, we've discussed the underlying themes in Margaret's, but here's the data, Marion.
Yes, so I know you'll have read the report, but just really looking at the dashboard, Just a couple of things I wanted to raise. You know that we're looking very closely about staff moves. They were very slightly up in April to 371. You'll remember a couple of years ago we were at 800 and something, so that has come down. But previously, over the easier months that we've had, a couple of them we were down to sort of 200. So we absolutely want to really concentrate on that. The other thing is the vacancy level, and we're still managing to recruit very well. There's some more difficult areas to recruit into, so we're looking at very sort of different ways and innovative ways to recruit there. We get a lot of help from Kate and our HR teams with that. But we're sitting at 2% vacancies for RMs and 5% for our healthcare support workers. I think compared to other areas on the Director of Nursing meeting last night, and we're in a very healthy position. We've also got a number of students that they generally all want to work with us. It's usually our first choice, so we're making sure that we have got space for them. And then probably just looking at sickness absence, which obviously we're looking at very closely line by line with these staff to support them to try and get back to work. And we discussed it at PCC yesterday. Just really to see if there are any nurses that aren't fit for whatever reason to do their day job. Is there anything at all that we can do to get their skills back into the workforce? And we will do everything that we can to support that, because that not only helps us getting them back into the workforce, but it also helps our staff's mental health and well-being. So we're doing a detailed support on that. And that's really all I wanted to say, unless anybody's got any issues. Community is going on, you know, we're talking about the acute side and the community here. We've done a lot of focus work in the community, and we've actually got one area of that to highlight, and that's the Alnwick District Nursing team that we're just out for staff there.
Thank you. This will have gone through SQI. Anything we need to highlight? No? Any other issues, Margaret?
It was just to comment on what you've just said, Marion. When I've been doing a number of walk-arounds, the amount of students who do want to stay in the trust and they're asking, you know, and really applying, it's absolutely enormous. So that's great. It is good. Yeah. And that's from all three universities that are here. Good.
Excellent. Allied health professional staff in insurance report.
Yes, again, I hope everybody thinks that we're getting more mature with this data, and we've had a lot of help from IT and informatics with this. Our actual the registered HPs vacancies have come down, delighted to see. And although the HPs themselves that are non-registered has gone up slightly, we are working on that. Our turnover is slightly up, and Sarah Weddell, who you know has been in the interim post for Allied Health Professional Lead, has been successful last week in obtaining that permanently. So it's one of Sarah's objectives to look at the turnover and rates and things like that. Again, sickness absence is up very, very slightly with the registered registered HPs rather. However, with the non-registered, that has come down quite significantly. So that's really pleasing to see. Again, I think from our students as well, working very closely with universities to make sure that we can have students across the whole of our Allied Health professionals, and we are trying to work very closely with the universities to make sure that we are able to offer that to particularly the smaller groups, particularly things like speech and language therapy, things like that. So that's work in progress. You'll see from an ODP, the operating departmental, that again is a very small service. It's very key to everything. So we're going to focus our work on that as well. We're generally happy with that.
Once again, as we've gone through SQI, anything to highlight? No. Any questions? Thank you. Complete the trio with the maternity update, Marion.
Yes, so the maternity update, there was just a couple of things I wanted to add, and Katie's very kindly done slides for us, which we'll have read. We're absolutely fine with the first couple of slides, and that's about our maternity incentive scheme and also our key year delivery plan. I just wanted to bring up just about the NMPA status, and that's the National Maternity and Perinatal Audit, that you can see that we were an outlier, just really to ensure the board that the team are all over this. Katie Barker particularly is Labour lead, and we've been looking at it as a deep dive, looking at our sections, looking at our APGAR scores, but also looking at the amount of mothers rather than patients that were SSRI medicated, and these are antidepressants for people that don't know, and they're the selective serotonin ones that you're allowed to have in pregnancy. So we're doing a wee bit of work around that just to see if there's any correlation. We've had a corrected adjusted result that's much lower now, 2.13%, and also looking at our retained information, which is avoiding our term babies into the neonates. The action plan's going on, and we are looking at the local and also the regional dashboard. So the team and myself feel comfortable that we've had a deep dive of that. We've readjusted our work. Sometimes it was comparing apples and pears, and we need to make sure that we're measuring the right thing. So happy about that, and I think you were too, Margaret.
Am I right in saying that across the region where there's more than one outlier, they're all finding the same things?
Exactly.
There's some data inconsistencies, and also one of the common factors being everybody that's an outlier uses Badgernet, and whether there's some kind of correlation there as well. But crudely, as a board, we're receiving assurance that whilst the data suggests we're an outlier, in practice there's no evidence to suggest that we're performing poorly.
And then the final thing was about North Northumberland, as we've already alluded to, just about the interpartum suspension of that service at the moment. We're working, so SQ and I, we've mentioned it there. We've also working very closely with the ICB, with the chief midwife there, and also the governance lead. And we've had various meetings about this. And it's also really about when we've got this in place with suspension, and people want to home birth, for instance, how we can individually look at that person, purely as an individual, and what we can bespoke for that patient. And we have got one or two that are going through that process at the moment, and every single one is different. The bit that worries myself and the rest of the team is about people that are high risk, that still have choice. And we are very much in discussion, both nationally and regionally, about what does that mean for people, particularly in very rural areas like us, where it takes time for anybody to get anywhere. And the other thing that we're looking at is an independent midwife service that we've actually signed up to. This is something that the ICB are running. They've been very much detailing the government's arrangements around that, and we're working closely with them. So we have one person in transit at the moment that's just coming up to term to put that in place, and that's been signed off by both the business unit, by the ICB, myself and Elliot and Jim.
That's great. Thank you. Questions, comments? Yes, Barry.
Thanks, Chair. Just to add that, as Marion said, this was discussed at SQ&I on 2 points. One around the visibility or consistency of the data collection around outlier status, and this was flagged with the ICB representatives in the room on at least 2 occasions. So they are cited on this, and there is work ongoing to standardize that. And we will probably see a shift when that takes place. And the other was around the high-risk births, the high-risk home births. This is something that we will be looking at very closely in terms of the outcomes for those mothers, birthing persons, and babies. So we are praying, we're saying, it's all in hand at the moment.
Very good. Thank you for that assurance. Then I think we're ready to move on. Learning from deaths. Alistair?
Yeah, happy to take that, Chair. The report's largely as written. I think, being honest, the most important thing is that the qualitative accounts, where I think there's some really good learning on some of the individual cases and some of the themes there, particularly the bullet points at A to E. In terms of the quantitative bits, you'll be, I guess the most reassuring thing is that the observed versus expected deaths is always in the right way, which I think from a reassurance point of view is important for the board. Clearly that doesn't extend throughout the whole of our winter period because we're still awaiting the analysis of that, but I think the inference is that on the data we've got so far that that will still be within those parameters as it's expected. So happy to take any questions.
Thank you. Really clear report. Any questions or comments? Could you, sorry.
It's just, and it's not directly related to this report, but it's just something the board will need to keep a close check on, and it possibly might come through S&Q as well, which is just the impact of the counting changes of SDEC and what that might have on the Shinny measure. And we just kind of need to watch this space a little bit as that feeds through, because we won't see the full effect yet. Just to keep a close check.
Absolutely, there's quite a big debate about how that's going to be accounted for, not just for us, but across the board. So we could see...
We could see a narrowing of the gap.
Well, just because your denominator changes, therefore it can affect things, so it needs to, what we then want to do is not to be in a position where you can't compare year on year because your denominator changes, and so it is something that we're looking at, and there's been quite a series of email trails we've all been involved with, because you need to be able to compare year on year, and if your denominator changes, we need to be assured that maybe we have to recalibrate some of that retrospectively.
Very good. Regulatory performance report. Chris, this also it's gone through FIP earlier on this week.
It has, yeah, and Bijou mentioned in her chief exec report earlier in the session, many of the members. Just one other thing, just to briefly raise, is we're still waiting from NHS England about their new performance assessment framework. So there's consultation until the 30th of May, which we've written back to them on. So we're just aware of that and making sure that we're over any of the measures that is included in the new framework. One other thing just to kind of also mention is one of the areas that we are getting scrutinised on increasingly nationally is about our elective waiting list size, which remains kind of quite stubbornly high. That said, we are, because of our 18-week performance, we are churning through them even though the wait list is high, but we will, I think, suspect get it under closer scrutiny of that detail size. We're working with the clinical business units around that. I think in terms of the rest of the measures, we're in a good place, but improvement across the board, and all of them is the name of the game and what we're working on with the business units.
Yes. Good. Any points, queries, challenges? Paul, the finance.
Yes, thank you, Chair. This was discussed at the Finance Committee on Monday. Just to say there's so far, as of month one, strong performance slightly ahead of plan. No issues to raise at this stage in terms of financial performance.
Thank you. Very straightforward report from you. Any questions or comments? Well done to you and your team, Paul. Thank you. Then we're into the review of the meeting. You know, at the beginning of the meeting, I thought it was going to be a real challenge to get through because we had so much material. But we're here. Does anybody feel that you haven't had the chance to comment? Have you been sitting on your hands, or have you had the opportunity to put your views open? Any reflections? Meeting going as it is? Are we still happy that we're systematically putting more business into the public board? Still seeing nods around that. We haven't had any questions from the public, which means I'm in a position to say thank you very much indeed. Meeting closed.